Good evening, everyone. I am very pleased to present this lecture for you. My name is Omer Abdelmageed. Mahmoud, I'm senior sonographer and ultrasound team leader at Sheikh Shalbout Medical City in partnership with my clinic. Today, I would like to speak about the reversal of flow in Doppler ultrasound from a sonographer point of view. And I would like to thank the page of Sudanese Sonographer Society on Facebook and YouTube for allowing me to present this lecture. I have no financial relationship disclosed. So in this presentation, we will have some learning objectives. We will realize the fundamentals of adjusting the technical settings and interpreting flow direction in clinical Doppler ultrasound practice. We will recognize the importance of comparing multiple vessels flow direction to confirm an abnormal flow in one vessel. And as well as we will recognize the pitfalls that might be encountered during the scan, which might result in a wrong interpretation of flow direction in clinical Doppler ultrasound practice. And we will implement all this acquired knowledge in this presentation in the daily clinical Doppler ultrasound practice. And there will be some real cases. There are 3 or 4. We will go through them. They are all from our ultrasound clinic in the hospital. So we have to speak about how should we optimize our Doppler settings before we go to the main topic of this presentation. We will not go through all of Doppler optimization settings. So we will just go through what we will get benefit from during this lecture, which are the Doppler gain, the color boxes setting, and the scale. So we can start with how should we adjust our Doppler gain. If you want to choose any study, and if you don't want to go through all these optimization things, you have to start with choosing the preset before starting the scan. What do we mean that? If you want to like start scanning upper arterial study, you should go to the settings on the machine and to choose upper arterial duplex or lower as you want or as you like to start with, because the machine should automatically adjust all the variables that you will need during the scan. Only few manipulation that will be required from you during the scan after choosing the preset. But generally, as a whole, if you want to do things manually, for color Doppler gain, usually start with increasing the color gain to the maximum until we see the noise outside the vessel. Then we will decrease and decrease until we get the filling of the flow inside the lumen without, this is just below the color bleed. Color bleed means the presence of color signal outside the true vessel. And if you did that, if you reduce the gain more and more, you might even lose the color inside the vessel. This might be wrongly be interpreted as absence of flow or a case of an acute thrombus, as in this case of portal vein, which is normal, but here we have a very low gain settings. Here it was about like 44%, and here we have it about 65. It was the optimum, and this was very high gain, as you can see here. The same things happen when you want to get the spectral Doppler flow, the spectrum of the pulse wave. You might start with increasing the gain to the maximum until you see this noise then reduce and reduce and reduce until it just disappears. So this should be the optimum or the proper pulse waveform that you should get. And if you lower the spectral wave gain more and more, you will lose the true peak systolic velocity point to things that are wrongly less than what it should be. As in this case, for example, the presence of noise will falsely give a wrong high PSV. It was measured here as 75 centimeters per second. And we will go to the proper gain. We will see that it was about 60 centimeters per second. And when we lower the gain more and more, it will show a low, which will show low PSV, which is also not a correct or proper gain setting. In this case of what we have to look for is the direction of color box steering. We should always avoid that the beam is almost 90 degrees to the vessel. Otherwise, we will lose the Doppler shift signal. And as in this case, this is not thrombus for sure, but because of the wrong angle of the color box, we couldn't get any signal back from the vessel. We couldn't get any Doppler shift back from the vessel. Then the only thing that we did here is just to steer the box. It's here along the flow direction. Now we are getting very nice filling of the lumen. This is a nice case of one of my patients. This is renal transplant, the right lower quadrant. In this convex color flow setting, we can see 3 colors. This is blue, red, and signal void here in the main for one vessel. So if I want to ask about what this vessel is, how can you answer? If I looked at the map, I will know that the lower part of the map will tell me that the flow is away from my transducer or the beam direction. So this goes away, and the upper part means the flow is towards the prop or the beam direction. So in this case, the blue here, so it's coming away from the kidney. Then it curves here to become like about 90 degrees to the beam direction. So we are not getting any Doppler shift. So there is like signal void here. Then once again, when the vessel leans up toward the beam, then I will get again another nice red filling of the vessel here. So we have signal point, another 2 colors all in one vessel. So this is for sure, this is renal vein. What should we also optimize is the pulse repetition frequency, which is also known as scale in some machines. It should be set to a level that will not result in aliasing. And we all know that aliasing happens when the sampled Doppler shift is more than the PRF over 2, or more than the half of the PRF. So if the Doppler shift is more than the half of the PRF, we will get an aliasing, either in the color coded Doppler scan or in the spectral wave Doppler scan. So what we know here is low pulse frequency will create aliasing, because as long as we are lowering the PRF, so we are lowering also what we call it Nyquist limit. We get the PRF over 2, so this will create an aliasing. In this case here, we have a PRF of 700 Hertz. What is nice here is you can see the common carotid and the internal jugular vein. So we could see the vein here. It has a slow flow, but because of the low PRF, we picked up the flow in the internal jugular vein, sorry. But at the same time, we got an aliasing in the common carotid artery. So because we wanted to get rid of the aliasing in this common carotid, we had increased the PRF to 4,500. We are having now very nice flow inside the CA, but we had sacrificed the slow flow in the interjugular vein. So high PRF will be at the expense of penetration and detection of low velocity flow vessels, and it will be measured in hertz. Here we can see the low velocity in the interjugular vein, and here it cannot be detected again. This is the same thing. This is when using color duplex. In the first image to the left, we have the PRF of 1,500. So we are getting wrapping around of the coded sample Doppler shift. And now it's if we have a map here of red and blue, aliasing will appear as wrapping around. In this case, it will appear like as blue in the middle of the puzzle. If you want to get rid of the aliasing, we will get the PRF. Here we have 4,000. You can see very nice flow. And again, this is very high PRF. And what we are seeing now is the loss of flow in the part that is flowing nearby the vessel wall. Why this happens? Because this is the slowest flow along the vessel lumen, because of the friction of flow with the wall. It will become slow and it will be very fast in the center, again slow in the wall. So rising the PRF will sacrifice the slow flow everywhere. In this case, it includes the slow flowing along the vessel wall. Again, you have a very high frequency here. You have a very an aliasing signal here happening. It appears as a wrapping around. We can see the baseline. It's here. If you want to get rid of aliasing, we have many things to do. We can either increase the PRF. So if we increase the PRF, we will increase the Nyquist limit and we will get rid of the aliasing. We can decrease the frequency because according to the Doppler equation, if we go through the equation and we know that the Doppler shift is proportional to the transmitted frequency. So if we lower the frequency, we will again lower the Doppler shift, and we will get a Doppler shift that is below the Nyquist limit. So we'll get rid of the aliasing. Also, we can lower the baseline, as in this case, in this image, and we can also increase the angle. Increasing of the angle also depends on the equation. As we are approaching 0, which is cosine of 90, we are at the same time reducing Doppler shift. So as we are going from like 0 angle to 90 degree, the cosine will disproportionately affect the Doppler shift. What I mean in this case is the value of the cosine theta will be reduced and it will be approaching 0. So at the same time, this will also reduce Doppler shift. Everything is about the equation. This is why increasing the angle will reduce the aliasing. So if we are going now to the main core of the topic, I think we are all familiar with the Siegel sign. And if you want to identify the correct direction of blood flow, we should know the correct sonographic vascular anatomy and the expected direction of normal blood flow. For example, we have this sagittal image for the lower vessels. This is the superficial femoral artery. We have the common femoral vein. We have the femoral vein. It's not known as superficial femoral vein. It was changed in 2002 to be named femoral vein instead of superficial femoral vein. We have the deep femoral vein as well at the same time. So as an anatomy, we have to know the direction of normal flow in a normal patient. So the artery will be flowing from the head to the toes for sure, and the veins will be flowing from the toes to the going up to the cephalic direction. This is what we have called the Segal sign before. We have to know the direction of flow in the Segal sign is formed of the celiac trunk with the common hepatic artery and the left splenic vein and the splenic vein, splenic artery, sorry. So we're getting the celiac trunk. We are having now the common hepatic artery, and we have the splenic artery. The left gastric artery is not shown here, it's part of it. The normal direction of flow will be from the aorta going up. So you should know what the flow direction should be before even starting doing any study. This is an anatomy and physiology. We should use the color map to identify the integrate and interpret flow directions. The upper part of the map means toward the probe. The lower part means away from the probe or the beam direction. So if we have this steered color box to the head side, and we have a map here that's showing red and blue. For example, you can choose, there is multiple maps that you can use in your machine. So flow coming from the head to the toes, it will be against the beam direction, as I can see. So it will be displayed as red, in this case. This is superficial femoral artery, and in the femoral vein, because it's going away from the beam, the beam direction, so it will be displayed as blue. So the color map should show you, should help you in interpreting the direction of flow. The same case happens here for the celiac trunk, as we have seen now. As per the color map, so the blood flow goes toward the beam, it will be displayed as red. Then they are all arteries, but because the angle of inclination showing that these arteries are going away from the beam or diving a little bit deeper, so they will be displayed as in blue in the color map scale. Good example also here for the splenic vein. Sorry. So we have also two colors for the same vein, because the blood coming from this side going to the spleen. So here is against the beam, red, and away from the beam is blue. You can see the same thing in the umbilical arteries and vein. And this is nice image also for the hepatic veins. So the right hepatic veins, they are going away from the beam direction, so they will be displayed as blue, but few confluences coming to drain in the right hepatic vein, so they are going against the direction of the beam, so they have been displayed as red as in the map. You should also use the comparison scan technique to identify or confirm a blood flow direction in a vessel. You should compare with the ipsilateral vessel, which this is what we mean is the vessel in the same side, and compare with the contralateral vessel in the other side. This is a very nice one. You will know you already know which one is having which direction. So this is comparative. The same thing as in the common carotid artery and interjugular vein, they have opposite directions of flow. And what you should be aware of is the invert function button. This button, if it's inverted, it might make it difficult for you to interpret the flow directions. It will invert the color map, it will invert the spectral flow direction and has no effect on the color steering box when using linear array transducer. So we will go now through our patients. The first one is 45 years old male patient. He has a history of colic liver cirrhosis, small hypertension, gastric varices, and broad hypertension, gastropathy. We could see the echogenic diffuse liver parenchyma, and there is some coarseness. And to confirm cirrhotic liver disease, usually we are using always the linear transducer to see the nodularity on the surface of the liver. So in this case, you can see some nodules here. So this is macronodular changes of the liver. And again, this is another one. This is one of my patients. So it's very obvious that this is cirrhotic liver changes. When interrogating the hepatic vein, what we could see here is the map telling me that blue color will be for the blood flow going away from the beam. We know that usually normally the portal vein flow is hepatometric, so it should go toward the probe, the beam, and should be displaced as in color. But in this case, it's blue, so it's coming away, so it's reverse flow in the portal vein, and I can see the same thing here when using spectral waveform. So this is a reversal of flow in the portal vein in case of portal hypertension. 51 years old male patient. He has previous hepatitis C, diagnosed 4 years before the scan. He has a history of prostate carcinoma, diagnosed 2 months before the scan as well. And it was done by one of my colleagues, sonographers. He is using very nice technique. In this case also there is flow reversal, it's blue, as we can see here. And the nice thing is what my sonographer did is comparing the portal vein flow with the hepatic artery flow. So they should be normally in the same direction because both are going to the liver. In this case, the hepatic vein, the portal vein flow is reversed, and the hepatic artery is having normal direction. So this was confirmative for sure. And the third case is what we know it as subclavian steal syndrome. In this case, it was the left side. The patient has interstitial disease and he was on dialysis. He is post arteriovenous fistula creation. It was left brachiocephalic. It was created between the brachial vein and the brachial artery and the cephalic vein. Clinically, he had weak thrill along the fistula, so they want to rule out any subclavian stenosis. Actually, the sonographer, when he picked up slow flow in the damped low velocity flow in the brachial artery, and this is subclavian, when he went up, he went more proximally, starting with the checking the vertebral artery and common carotid artery. Sorry. So we can see here that he interrogated the left common carotid artery, so all the things on his left side. And as per the direction, we can see the color steering. It's here. Because the map showing me that away is red, so the blood in the common carotid is going up to the head, so it's away here. it's red, so it's normal. What is abnormal is that when he interrogated the vertebral artery, because they should have the same direction of flow. In this case, the vertebral artery was, you can see that both maps are fixed. There is no change, but there's another flow direction for the vertebral artery, which, as we said, they should be, the common carotid and the vertebra should be at the same direction. Here, the vertebral artery came, it was reversed, so it was coming from the head down to its branching. The cause of this was a tight stenosis at the origin of the subclavian artery on the left side. Okay, when we said before that the invert button will invert the color box, we meant this thing. This is why we have to make sure that my optimization was good, and the invert, either if you activate it or not, you should interpret your image accordingly. So it was not only comparing the common carotid with the left vertebral artery, but the sonographer also compare the left vertebral with the right vertebral artery, so we can see the difference in flow direction. This is the normal flow direction toward the head, and this is away, going distal from the head. This is the case of subclavian steal syndrome. See the subclavian artery itself, it's in the mid, and here we can see the brachial artery. There is very damp flow in the brachial artery compared to the subclavian. So this is the thing that had created the weak thrill in the fistula. They did angio and they found the stenosis at this level. The vascular surgeon, they put stent here, and the flow again was retained back normal to the left brachial vein, as was in the documentation for this patient. We did not get the patient back for post-operative assessment again. We have a patient of brachial steal syndrome. This happens when in patient those having brachiocephalic fistula. This 67 years old male patient. He has failed brachiocephalic fistula, and then they had created graft from brachial artery to the antecubital vein, as we can see here. In this case, our sonographer, the same, brilliant sonographer, he had also, he was tracing the arteries and veins, and in this case, when he went to the forearm following the brachial artery, this is more proximally, there was nice high velocity, high volume flow. And as he is approaching the graft, which is here, we are still seeing a good velocity of flow, and it's antegrade in this case. At the site of anastomosis of the graft with the radial artery, there was a very high velocity. We are interested here is making sure that the flow is going to the hands. In this case, it was not. We can see here that this is the color box, the beam steering. So the beam is directed towards the head. So, and as we can see the color map here, we can expect that the red is up. The red means any flow towards the beam should be red, and away from the beam should be blue. So this one here, so this is a brachial artery flow. So it's coming away from the, instead of going from the head, from the shoulder to the hand, it's going from the hand up in a retrograde manner. So in this case, it's reversal of flow. And this is why that we have to make sure that our settings are correct, and we have to make sure that we are interpreting the normal flow direction also correctly, and we have to make sure that the map is correctly and there is no invert button. So the sonographer he has just steered the color box. There is no change in the map, as we can see here. So now the blood is coming toward the beam, so it is displayed as red. So it is not the normal direction. The normal should go away toward the hand here. And the nice thing that he did also is comparing the brachial artery with the ulnar artery at the same forearm. So they should have the same direction of flow, but this is normal flow, this is abnormal flow. So this is reverse in the radial artery. So there is a stealing. The fistula is stealing the blood from the radial artery. As summary, proper anatomical and physiological knowledge of vasculature is essential. Set color map appropriately. Compare flow direction of at least 2 vessels and pay attention to the invert button. We have the references, and thank you very much for your attention.